these are my disclosures. In fact, none of them really relevant for this presentation. I'll take a little bit of a broader perspective. I will, of course, discuss the dangers of deresuscitation or de-escalation, but I first want to start out with putting things into perspective. What exactly is de-escalation, deresuscitation? How should we be using it? And at the end, I'll give you some, well, practical strategy you can use at the bedside in your unit. Of course, you know, this conceptual approach to fluid therapy in the critically ill patients, I think you will agree with me that much of the attention is actually not so much on the last part of fluid management, but more on the salvage or rescue phase. Yet I will try to convince you that also this final phase is very important, and we should really be putting more energy and attention to that final stage, where indeed achieving a negative fluid balance is the goal, but how, when, and how fast are important things to consider. This is essentially the same idea, but more focusing on the fluid balance. If you would then translate this to the actual targets that you need to have in your patient, you can see here that indeed at the end, the final stage of fluid management, the de-escalation phase, is where you need to get this negative fluid balance, and probably that should be balanced against the positive fluid balance in the first stages. Now, it's often quite challenging, of course, to do this. Now, very important, and I really think this is critical, fluid overload has a lot of negative effects. It affects all organ systems, and I think you need also to take these clinical effects of fluid overload into account. We often forget that there's clinical symptoms related to fluid overload. These are essential and should be the trigger to therapy, and probably not so much the numbers, the cumulative fluid balance, or anything else. Well, there's plenty of evidence, and I'm sure you will already have heard a lot of data on this at this meeting, that there is this link between fluid overload. This is just one study showing you that in gray, the non-survivors have more positive fluid balances throughout therapy. Mind you, though, that this is an association, and it's very difficult to show any causal effect here. Yet still, I fully agree, fluid overload is important, but again, take it into perspective. Still, this is where this is how many of our patients end up, of course. Again, we've been much more restrictive in the past years because, well, we know about fluid overload, and we're much more judicious with our fluid therapy in the first stages of treatment. So always, again, take a clinical perspective, try to look at the patient and make sure that you have a reason to de-resuscitate or de-escalate in these patients. Lots of our presentations here on this meeting, lots of our discussions are about fluid therapy, giving fluids, and not so much removing fluids. It's about the type of fluid, what endpoints we should be using, what devices we should be using to monitor this. But when to stop and how to remove it is something we don't think of all too often. Again, going back to this, I would like to remind you that what is even better than having to remove fluids is not giving too much fluids in the early phases. So that's, of course, a no-brainer, especially in this stabilization phase. I think it's important to avoid fluid creep. Have a critical look at your maintenance fluid, at all the other fluids that are needed for medication, and take this also into account. Have a look at the cumulative fluid balance at every stage of the resuscitation phase. Our PDMS systems that we are used now, well, they're very effective in doing this, and it's quite easy now to keep track also in a patient that has been in the unit for quite some time, to keep track of this cumulative fluid balance. Now, that being said, I think it's quite challenging to really identify this turning point where the patient indeed is ready for fluid removal, and also keep in mind that this patient can go back and forth between these different stages. Sometimes a patient may need a reoperation or has a new sepsis episode and may actually be going back from here to the optimization phase and back. So this is more conceptual approach, and the patient can move between these different phases. Now, there's a lot of discussion about terminology. Personally, I don't like too much deresuscitation because it's kind of like the opposite of resuscitation. Resuscitation quite often is very limited in time, much more aggressive. I don't think this applies to the deresuscitation phase. De-escalation has been used fluid removal is probably the best descriptor of what we do. But they are used, all of these different terms have been used. They have a similar goal, though, which is removing the fluid to avoid toxicity. And again, this toxicity, I think, is a prerequisite to initiate fluid removal. So these are our main strategies to do it. You can either use the patient's kidney. Of course, in case of acute kidney injury, this will be very difficult, and this is why in some patients we will need mechanical treatment. And I'll leave much of the discussion about mechanical treatment to the next speaker. Diuretics are drugs we use quite often in this phase. Of course, they're very easy to use and to administer, again, only in patients that have some residual diuresis left. Could be recovering AKI, but they do have some side effects, most of them metabolic, especially when you give them in a, well, not so well-controlled way. Electrolyte disorder, metabolic acidosis, and also worsening of acute kidney injury are indeed a relevant risk, apart, of course, from a more global problem as hypotension and hyperperfusion of the patient. So important to keep in mind. This is also why I like to give diuretics in a continuous infusion, and most of the time I start at a pretty low dose and initiate and set a target, set an hourly target of how much of diuresis, how much of urinary output you want to see in the patient. But I'll come back to that in a minute. Ultrafiltration, well, it gives you the advantage of complete control over the rate. That's very easy. The negative side is that, well, it's an invasive and an extracorporeal technique with all the negative aspects that may be related to the use of mechanical removal. Again, the next speaker will no doubt talk more about that. Please do mind that in some of our patients, the fluid overload is compartmentalized. And I'm not sure if the removal techniques with diuretics or ultrafiltration is the appropriate way to do. I think if you have a massive pleural effusion, I think it's an illusion that you can remove, well, ultimately you may be able to remove it, but at the expense probably of side effects, many side effects. I think these patients, whether it's pleural effusion, whether it's ascites, should have a targeted therapy, and a percutaneous drainage is something to be considered primarily in these patients. But many of our patients maybe don't need anything. If you have a patient who's doing well, some of our patients mobilize the fluids themselves, and it may take a little bit more time, but if you have no toxicity, doing nothing, and I know many of us have a lot of difficulties with doing nothing, but once in a while, doing nothing may actually be the best strategy. So how should we be monitoring? That's a very difficult thing. We use a lot of parameters and machines. Don't forget, of course, you always need to think when you use these devices. And when we look at hemodynamic monitoring, you can take whatever you use to monitor resuscitation and use it, well, in the opposite direction. That's probably what we do, but there is very little, if any, evidence supporting this approach. The same for biomarkers. Should we be using lactate or transient lactate, hematocrit, relative blood volumes, BNP, other parameters? Unsure. They are being used to guide the de-escalation phase, but I'm unsure if this is really what targets we should be using and if this is really what we need to do. Clinical evaluation, absolutely. Signs of hyperperfusion may be subtle at the start. I would really recommend you to take a regular look at your patients when you use this. Vasopressor dose, I'm not sure if the patient needs to be completely weaned off vasopressors before you can start this. Sometimes it is possible, and I'm sometimes surprised how patients tolerate ultrafiltration or diuresis in our ICUs. These are the different things to consider when selecting the method and the rate. Well, first of all, the extent of fluid overload. Look at your cumulative fluid balance. Look at the organ dysfunction. And again, this is critical. Organ dysfunction is something I think is required to initiate fluid removal. And of course, it should be guided by the organ function itself. Now, particularly this organ dysfunction attributable to fluid overload is difficult. Take a patient with acute pancreatitis. They get a lot of fluids, but there's also the inflammatory process itself that causes organ dysfunction. And telling which percentage actually is caused by fluid overload and which is caused by the disease itself, it's often quite hard to say. Also, mind you that not all patients need the same aggressive approach. And you can see in this slide, this is very nicely depicted, that some patients, well, need a more aggressive de-escalation at the beginning and then a more gentle approach. In some patients, you may need to wait a little bit before starting the de-escalation, and others you have maybe to escalate before being able to de-escalate. So one-size-fits-all approach, I think it doesn't work. And never forget, I mean, these are ICUs. We have also these fancy machines. But once in a while, please look at the patient. The patient is the one in the bed, right? And we need to take a regular look at the patient also when de-escalating our fluids. So in the practical, at the bedside, I think the first step is to estimate the cumulative fluid balance. And again, our PDMS systems are very potent at doing that. Check for toxicity. Is there organ dysfunction that can be attributed to fluid overload? That's the next step. Patient stability, difficult to measure, but I think you need to look at the complete picture. Then, based on these parameters, choose your method for fluid removal. And very important, select a goal and timing. You should be aiming for, say, -2 liters in the first 24 hours, or in the first 6 hours, -500, and then re-evaluate the patient. When I prescribe diuretics, for instance, in a patient, I never set the dose, but I say, well, we need to get 150 or 200 mL per hour, and then we'll see if we can increase or we need to reduce. Throughout this process, re-evaluate. Regularly check on the patient if the patient is doing well. There are some dangers, and just as a reminder that not all of the side effects are immediate. I'd like to remind you of this study, of course, the FACTT trial, looking at restrictive versus liberal fluid management in patients with acute lung injury. Not so much the primary data. Remember that there was a shorter duration of mechanical ventilation, but more worrying was actually the follow-up of these patients. And this is a report on the neurocognitive impairment, and it was found actually that patients in the restrictive fluid management had a higher degree of neurocognitive impairment at 2 and 12 months. So maybe not all of the effects can be measured and can be seen immediate. And this also shows us that we actually need much more information. So fluid management, it's a balancing act. It's a balancing act in the rescue, in the optimization phase, but also in the de-escalation phase. It's about, do we need to de-resuscitate, to de-escalate the patient? How fast? When is the appropriate timing? And please be as cautious in the de-escalation phase as you would be in the resuscitation phase. So in summary, Mr. Chairman, ladies and gentlemen, I think it's common practice. We do it a lot, but we have actually no clear idea what we are doing. The exact timing, when to start with it, it's difficult, and we need more information. Two main strategies remain diuresis and de-escalation, but again, once in a while, a patient may need another strategy, such as doing nothing. The dangers are multiple. We focus on the short-term dangers, metabolic, potassium, sodium abnormalities, but also do consider that there may be more long-term effects as well. And there's definitely an area where we need much more data in order to optimize this particular final, maybe less interesting part of the resuscitation. And with this, I'd like to thank you and end.